Good afternoon, everyone, and thank you for being here with us today. I am Marina Terraforte Smith, the program manager of the JHM Wiki program. For those of you who have attended our sessions before, you know that I am typically behind the scene, and that suits me just fine. However, I'm thrilled about today's toolkit episode, so let's go ahead and dive in. Let's see if my slides will change. There we go. Before I introduce you to today's speaker, I wanted to share a little bit about who we are and why we're here. JHM Wiki is a collaboration between the 5 distinguished programs you see listed here. These programs provide comprehensive care for women, infants, children, and youth living with HIV. Our vision is to enhance HIV care coordination and establish interconnected systems that enhance their overall quality of care for everyone. Our mission and how we plan to achieve that vision is to collaborate and coordinate across systems of care to build upon existing structures. And that is why this platform serves as the signature space for engaging and amplifying you, the experts. Our goal is to engage and amplify your expertise. If you have insights to share or know someone who should be in this space, please reach out to us. But today I am so excited to welcome Katelyn Riegger, my partner in crime and good deeds, my coworker, and someone who I am so proud to call my friend. Katelyn is a licensed certified social worker with a dual master's degree in public health and social work from Johns Hopkins University and the University of Maryland. She has extensive experience in providing sex positive, trauma-informed populations. With a strong background in research, Katelyn brings versatility to her role, wearing multiple hats in grant development, clinical care, and program implementation. Currently, she serves as the program manager of the PAHOP program, where she coordinates a comprehensive care model for young patients under Ryan White. So without further ado, Katelyn, take it away.
Wonderful. Thank you so much for the introduction, Marinas. I appreciate it. I'm going to share my screen. Give me 1 second.
Right.
Can you see my screen okay, Marinas?
I do.
Okay. So this talk today is called Honoring the Journey, Trauma-Informed Support for Lifetime Survivors of HIV. I want to highlight in this talk the unique experience that lifetime survivors have compared to other unique populations that we tend to focus energy on. Hopefully today we will cover an understanding of trauma's impact, what trauma is, how it affects individuals, break down some barriers addressing misconceptions about trauma, and reframing to focus on strength and resilience rather than pathology, recognize the resilience of people living with HIV, as well as anyone who's experienced trauma, and discuss hopefully how to create safe spaces, how to strategically build trust, safety, and connection in the healthcare space. And we'll wrap it up trying to create a blueprint for what trauma-informed care could look like based on some of the principles and evidence-based practices that we already know. What is trauma? I think I hear the buzzword a lot. Trauma, trauma, trauma. Trauma-informed this, trauma-informed that. But the definition is really what happens when something overwhelms your ability to cope, and it leaves a lasting impact on your body, your emotions, your mind, that it can come from a single event, or it can develop over time from prolonged exposure to stressful situations. But either way, it creates lasting impacts that change how we navigate the world. When someone experiences trauma, it can impact how they trust people, how they handle stress, and how they view the world around them. As healthcare providers, if we understand trauma's impact, we can create more compassionate and effective care environments for our patients. How trauma becomes complex. Complex trauma involves recognizing how traumatic events can accumulate from multiple adverse experiences over time. Some of these beginning in early life and continuing across the lifespan. We know that for lifetime survivors, and I'm defining that as people who acquired, who were either born with or were diagnosed with HIV before the age of 5, are considered lifetime survivors. Some of the foundations of health risks and mental health concerns were laid as a foundation before the person was even born. That intergenerational trauma is trauma that gets passed down through families. Those experiences of poverty, of violence, discrimination, those affect multiple generations. In addition to that, medical trauma, distressing experiences in healthcare can really impact how people navigate their healthcare experience. Furthermore, developmental impact is important. How trauma during developmental periods can affect brain development, affect attachments, how we have relationships with other people, as well as our ability to regulate our emotions. We also know that ongoing experiences of discrimination, marginalization, and systemic barriers continue to act as microaggressions and micro traumas layered on top of these other experiences. Whoa. Did it zoom like crazy for you? Because it zoomed like crazy for me.
Katelyn, we're seeing a web page, and I'm not sure if that's how you want it to display. There we are.
Okay. Is it full screen?
No, we are looking at the web page. There we go.
Okay.
Perfect, perfect.
Trauma not only affects relationships and brain development, it affects the whole person. It has emotional impacts. We experience cognitive changes as well as things that are lasting as physical effects of trauma. Chronic pain, fatigue, sleep disturbances. For anyone who's read The Body Keeps the Score, your body can hold memories and respond to perceived threats based on the trauma that you've experienced. To understand complex trauma survivors, we as providers need to understand just the layers of trauma that significantly contribute to how people show up for us. To really give trauma-informed services, we have to be available for people as they are, and understand that in extreme circumstances, which they may still be living in, they are managing the best that they can, and that they may be in that survival mode for the entire time that they're your patient, or the entire time that you're a part of their life. And so understanding what they bring when they come to a visit, when they come to you for support, um, what what that's like, what they're carrying. Um, that part of being trauma informed, it's really the foundation of being able to provide quality care services. We we also know that there is a historical weight of trauma. Um, this includes, specifically for people with HIV, how they experienced the early days of the epidemic, how they experienced that for lifetime survivors as small children, how they were going to funerals and losing loved ones, and understanding the weight that they carry in such a way that maybe there's a survivor guilt for some patients, that they continue to be able to live now with HIV past other folks, and that can hold its own traumatic experience. Um, it also leads to a lot of medical mistrust, the way that the early treatments were provided, the amount of medication that people had to take. It was incredibly hard, incredibly difficult, and doing that as a lifetime survivor means that you are experiencing that from being a young child. You're coming into the world already, having these experiences of the harshness associated with the medical framework. Um, and it also, takes into consideration the ongoing current experiences of discrimination and systemic barriers that just add to this compounding layer. And this is before, we add any ACEs, we add any adverse childhood experiences. This is just out the gate, the the historical weight of trauma that people carry with them. And if providers fail to understand this context, then they're failing to understand patients' identities, relationships, and how they are interacting with the broader healthcare system. As I was saying, these layers just keep building on, just keep piling up. Um, the early life trauma of childhood adversity can be further intensified by the developmental challenges, academic struggles, other implications of these traumas, and only for that to transition into adulthood, and impact relationships and employment and have ongoing health issues. Um, some of the lifetime survivors that I've talked to have said, they didn't expect to live to have gray hair. They didn't expect to live to be adults. And now that they are adults, they have a new set of challenges that they're experiencing related to their HIV. Hidden trauma responses, these are things that they're hidden, sure, but if you think about them, they're also ways that, we start to respond to trauma internally. There are things that you feel, that anxiety, that elephant on your chest, those sort of trauma responses combined with wanting to skip appointments, avoiding procedures, shopping for new providers, it creates a complex and a response that makes it even more difficult to stay adherent and stay connected to the medical system. We also see that folks face complex healthcare navigation. They have been experiencing the trauma of HIV across their lifespan, from the foundations that were laid as they were developing through receiving medication as young children, coming to understand their diagnoses, coming to learn what that means for puberty and for new sexual relationships, changing again as they move into adulthood and navigate insurance changes and go from pediatric care to adult care. It's exhausting. It is exhausting, and it keeps compounding. Somebody from our clinic said this week that the responsibility of having HIV in a relationship is so heavy that they carry that responsibility every time they go out on a date, every time they think about getting involved with someone, the responsibility of having to disclose their status or explain where they are with their care, explain, what their relationship with HIV is in the current state. And that is something that's not talked about as often, is just how the relationship with HIV changes across the lifespan, that it is impacting people at every developmental phase. And for someone who's taking medication and seeing doctors for their entire life, this becomes so exhausting. They're telling their history again and again. They are changing providers, changing healthcare spaces. And these transitions are often a place where we lose people, where we feel these fragmentation of services. That's where we get some of the most loss to care. But there are also times when people are just done with taking medicine. Like, it's too much. They've been taking it their whole lives. It's not uncommon for people to need medical breaks in their medication and their care. I'm wondering if there are any questions before I move kind of into the next section.
There is a question for you in the chat. Jatoya asked, how can we help patients through those hidden trauma responses, such as avoiding many missed appointments?
That's a great question. And I think I might answer that here in the next section. One of the ways that we can support people who have experienced trauma is to show up for them, is to be considerate of their lived experiences. They should be over it by now. They're being dramatic or attention seeking. There may be true neurobiological reactions to what they're experiencing. Trauma can create a range of different responses, and it doesn't go away. Like, it's not like, great, you did it, the trauma's done, packaged, on to the next one. if we as providers minimize trauma and minimize these experiences, it's actually harmful to how people heal and how they find relationships and attachments as they move through life. A lot of one big misconception too is if they're functioning, they're fine. I don't know how many of you have been like, I'm fine, I'm fine, I'm fine, sure, I'm fine. But you're not fine. There's survival strategies that we all use to get through the experiences of daily life, but that doesn't mean that they aren't still experiencing symptoms, that they aren't still struggling with adherence. Even your most adherent patient could be struggling with impacts of trauma. Has anybody encountered these impacts or misconceptions in your care setting or even just your own life? Right, and that shows up as fear, right? Being scared to know, like, I feel like a lot of our patients, even a lot of the people around me, are living in survival mode, just waiting for that other shoe to drop. And that keeps your levels of cortisol, your levels of stress up here. You're starting the day already stressed, already in a state of anxiety, distress, and that's not you can't start at a 7 and, you know, expect to not be maxing out with stress every day. That burnout, that stress chronically can really manifest in other symptoms as well, and can manifest as physical symptoms, pain, and other issues that people are facing.
And as Toya shared here in the chat, yes, go ahead.
You've said these to yourself, Toya. I think too, when like as a pediatric provider of services, we tend to see people as they're becoming teenagers and as they're becoming young adults and navigating the world for the first time on their own. And when they come to us over and over and over again for this thing or that thing, it can feel dramatic. It can feel attention seeking, or, you know, like an overreaction. But if they're coming to you with this stressful experience, with this problem they're trying to solve, you're a safe person for them. You are a safe place for them. It may seem like someone is overreacting or is overdramatic, but that's a trauma response. They're in survival mode, and they're coming to you because you are someone that listens to how they're experiencing life. Oops, okay. I talked about this a little bit, but the healthcare fatigue is real. It is hard to juggle multiple appointments, multiple specialists, treatment plans. If people are facing challenges and past experiences, it doesn't mean that they are neglecting their care. It doesn't mean that they don't want to participate in their care. They might need a different approach. I always think that it is one of the most interesting things to see how your provider talks about you when you're not in the room. And I say that as someone who has looked at a summary of my visit notes to see non-compliant at the top of my visit summary, but not anymore around that topic. Not, oh, the prior auth expired and she needed another this and she needed another that, and now we have to place another order. Not any of the barriers, not any of the challenges that it took me to get there, just non-compliant. And that is painful and hard as a patient, of someone seeking care, to see how you are described and talked about by your provider. The things that you write in your notes, in your clinical observations. A lot of people have access to these now, and it's important to also recognize the strength of your patients and of the communities that they're in and the ways that they have survived up to this point. It is incredible, the resilience that people have, but it doesn't mean that trauma disappears. It means they've found a way to keep going, growing, and getting through life, but it doesn't mean that it doesn't contribute to their everyday experience. Some healthcare can be expensive as well. Absolutely. There are barriers that, I mean, trauma informed, this isn't even to the barriers yet, you know? Talk about expenses, co-pays, deductibles, insurance lapses. The challenges add up and up and up. And so to me, when my patient arrives, I'm just thankful that they made it because I know that they took 3 buses and one was late, and they've had their child in a car seat, and they tried to be there, but life be lifing. It is difficult sometimes, and there are hidden strengths and expertise that our patients have that it is important for us to highlight. Folks that we serve here in our clinic, they are phenomenal at navigating some of the most complex systems. They do know a lot about resources, and they do have good networks and support systems that we should highlight and lean on as providers, and challenge folks sometimes to recognize those strengths within themselves. The advocacy skills too of some patients, it's become a necessity for them to advocate for themselves through their lived experiences. And that's another thing that should be highlighted as a quality of resilience. What is trauma-informed care? This is what the textbook will tell you is trauma-informed care. Trauma-informed care is safety, is trustworthiness, is cultural humility, is peer support, empowerment, and collaboration. Trauma-informed is not telling your patient they have to go home when they are 15 minutes late and it's past the window that they were supposed to arrive. Trauma-informed is not putting non-compliant at the top of your patient's chart. Trauma-informed is showing up for your patient and taking them where they are, how they are, with what they have. And that is difficult because sometimes that is in direct opposition to the systems that we're providing care in. And I know we like to label everything with trauma-informed care right now, but I would challenge you to think of a place that is doing it well. Because the trauma-informed systems that I know do part of it, but safety, but empowerment, but only if it's 9 to 5. Safety only if it doesn't challenge any rules of the space, or, you know, trustworthiness, but it's a teaching hospital and sorry, we have new fellows next year. We have things in our systems that are in direct contrast with being able to provide trauma-informed care. And it's important that we recognize those shortfalls as well. Trauma-informed care is inherently difficult to do well. Healing for patients and longtime survivors means establishing safety within their groups of people, within their communities. I said this in the last time I gave this talk, and safety and support is having people that will let you hurt out loud, that will let you say what you need to say, be who you need to be, and will not try and fix it necessarily, but will just sit with you in that experience. And I know for me, a lot of my hurt out loud people are on this talk, and it is important to understand how trusting relationships and safe relationships work towards healing those traumas. There are support and coping strategies that we can provide to folks as part of implementing trauma-informed care. Emotional regulation, social connection, physical wellness, meaning making. But we also have to tailor these to our patients. I think a lot of models of trauma-informed care neglect to consider the resources that people actually have. I think a lot of trauma-informed models are based on a middle-class ideal of healing and resilience for people that can buy bath bombs and sit with eye patches in the tub. If your patients aren't able to have those sort of self-care healing experiences, what can they do? What is a small way that they can find joy, that they can find connection, that they can reinvigorate a relationship? Even those small pieces, those small changes can start someone down the path of healing. Anybody else have good supporting coping strategies that they want to contribute? I know I have had some luck when it comes to just breathing, just taking a minute to breathe. Deep breathing, holding my breath, counting, and letting it out. That's something I can do. It doesn't take any money, it doesn't take much time. And deep breathing exercises naturally help regulate your body, will help reset the systems in your body to be able to regulate and decrease some of that cortisol that is pulsing through when anxiety and stress builds up. Working out, taking a walk. Some coping strategies have their own sets of barriers. Naomi, would you mind saying more about that?
Yes, so sometimes, like taking a brief walk, we don't know if the patient has a disability that may not be beneficial to walk. Sometimes patients can have trauma in regards to being mindful, like doing mindfulness practices. Um, I once had a client who, when I often told them, okay, let's relax and breathe, they will often have a panic attack due to trauma they had related to that, to an incident with that. I will also say, like, even eating healthy, like, I don't know, can you go back to the coping strategies real quickly?
Right.
So sleep hygiene practices, are they able to have 8 hours of sleep, right? They may have to work 2 jobs because of those systemic barriers that we speak of, right? So can they get that adequate 8 hours of sleep if they're working 2 jobs, right? Nutrition and self-care, especially in Baltimore City, there are food deserts. So do they have access to nutrition? So I would say that oftentimes when I'm working with a client, I try to see what tools they have that we can strengthen. So that's how I individualize it, because if they have food deserts, if they're not able to walk, if mindfulness doesn't work for them, what are some other things that are accessible to you to ensure that you are coping with your trauma?
Did my screen share pause?
Yes. Right now, we are currently seeing a black screen.
Okay. I'm trying to resume it. It doesn't seem to want to resume. Give me 1 second. Apologies. No. Still nothing.
No, right now it's saying you've started screen sharing, double click to enter full screen. Let's see. Still nothing.
I'm gonna stop sharing and retry again. Still not. Okay, I'm gonna know it. Apologies. It's back. Right? It's back.
Yep, it just came back.
Okay, good. Is it still back?
Yeah, it's still there. I see supporting coping strategies slide.
Okay. I appreciate your perspective. Naomi, because I think everything that you just said, these are some of the real challenges with implementing a trauma-informed care model, that we have coping strategies that don't fit the needs of our patients, that don't fit their realities. And that is inherently flawed. We cannot call something trauma-informed if we have no intention of understanding what it is that our patients actually need and how they actually live their experiences. We know that people are the experts of their own experiences. And so I like what you said is, how do you typically cope? How does coping work for you? Are there good coping strategies and bad coping strategies? Absolutely. But understanding those from the perspective of your patient is incredibly, incredibly important. Yes, thank you, Jenna. I think also in connection with that is that understanding as a provider that something you think is a good coping strategy may not be a good coping strategy for somebody else. That what works for you may be harmful to somebody else, and what works for them may not fit your definition of coping or good coping. But by starting somewhere, by starting with understanding, we can help people with trauma begin to heal and begin to feel supported in our healthcare environments. Building the ideal care model really means considering how you implement trauma-informed care from the ground up. If your space is not trauma-informed, if your security guards aren't trauma-informed, if your registrars aren't trauma-informed, each place that somebody interacts with, the space, the people, the atmosphere, that impacts how they receive their care. It's not trauma-informed to turn people away because of this rule or that rule. It is not trauma-informed to not have language services available. It is not trauma-informed if you have no flexibility in your practice. We know people that are bringing the most trauma need understanding and flexibility in the approach. And one thing that I have really been challenged by with this idea is how do we balance both, right? Because you want to be trauma informed, but you also need to keep providers safe, or you need to be flexible, but then how do people get seen? You want to have people with lived experience, but they have challenges connecting to different folks that come through the door. How do we balance these inherent opposing challenges? And that's something that I don't think I have an answer for just yet, because it has to be a systematic change. It has to be an informed change at every level to truly be trauma informed. Just saying it and putting it on a sign does not make it true. What can help make it true is consistent care teams, having the same providers be available to the patients so that they aren't rehashing stories, so they aren't being re-traumatized every time they come to their appointments. Having flexible service delivery, telehealth options, extended appointment times, and accommodations that aren't punitive. And that one is tough. Like, that one I've come up against in my own experiences of being hit with a full charge because I didn't make it to an appointment. And there were extenuating circumstances, but I couldn't be afforded that understanding, that accommodation, and there was a punishment. That doesn't feel trauma informed. What does is integrating your services. If you can make the one-stop shop happen, that's the best possible scenario for your patients. If they can come and address multiple things at the same time, then you're making the most out of the time that they've been able to allocate towards addressing their healthcare. To take off yet another day, pick up another kid, catch another bus at another time. That is what is tiring for people. That is what makes it unbearable to navigate some of the complications of the healthcare system. So being able to integrate services is a huge highlight for trauma informed care. And also patient leadership. People are the experts of their own lives. For them to inform program design and service delivery is crucial. It shouldn't be what you think your patients need. It shouldn't be what the system thinks your patients need. It should be your patients having the opportunity to say for themselves what it is they need, how they need it delivered, and then framing the approach around those items. How can we do this? We can build awareness, foster collaboration, and campaign change. I think the investment in trauma-informed care is bigger than what many places are currently doing. I think for us to label all these different programs and practices as trauma-informed is really not true. Because the models of trauma-informed care fall apart when the experience from top to bottom is not understanding of an individual's trauma. And that's pretty much all I have. I appreciate everyone's attendance on here, and I'm open to some questions or considerations for what do you think the trauma-informed care model should look like? What are we getting wrong? I told you what I think we're getting wrong. Anybody?
I don't think something that's wrong per se, but most times like example I already expressed like the coping strategies and stuff like that. I just feel like sometimes when we're thinking about trauma informed, like individuals that's dealing with trauma, especially those living with HIV, that they don't have even access to cope, right, with those coping strategies. So I think sometimes, even though we have all this information to provide to them, how accessible are these resources to them to utilize those tools, if that makes sense? I think that has been the biggest barrier for me when I'm working with clients. It's like, okay, we have all these resources, we have all these tools, but they don't know how to apply it, or they just don't understand how to apply it. So I think that's my biggest issue with trauma informed care, is that we're working with individuals that have so many barriers and so limited accessibility to this care, and to even implement it, even though they have access to that care.
I think that's an incredible point. And that's really where, for me, trauma-informed care goes fundamentally south when it doesn't meet the basic need of our patients, and can't meet them where they are. When they aren't available to even try coping strategies, because there are continued traumas coming in every day.
Exactly. Yeah.
On kids or
Yeah, I mean, we can look, but I don't remember Mavis ever having any of those.
The hidden responses to trauma-informed care, Toya, that's a big one for me. I think as providers, we should be more aware of how we're labeling patients, of how we're thinking about patients. You know, are we talking about them from a lens that acknowledges their trauma? When I look in my chart and it says, Katelyn, single, activities none, pets none, exercise none, like you're not chalking me up to being a great a winning person here. It's important how we talk about our patients and how we view their experiences, how we understand how they got to where they are. Yes. Yes, that's exactly right, Naomi. Trauma-informed care is built from a place of privilege, and we are not realizing how that power differential impacts our clients and impacts the care they're receiving. Ooh, Marina's. How do you bring your own trauma into the room? That's huge. If you as a provider are carrying your own heavy load of traumatic experiences, how are you showing up for your patients? How are you recognizing their trauma in a way that doesn't, you know, project something onto them? Or how do you come out of the visit without being secondarily traumatized yourself? That does impact how we meet our clients where they are, including the biases that can bring into the room. That's a really good point, Marina's. I appreciate that one.
Thank you. And if there are no more questions or comments today, Katelyn, I want to thank you for joining us. This was a great talk. I really appreciate it, and we're looking forward to continuing this conversation. I think trauma-informed care is definitely a hot topic, but not something that we are willing to let go anytime soon if we want to continue to provide that care to our patients. So thank you again to everyone for joining us. Oh, I'm sorry. Go ahead. One more comment.
I'm sorry, I just wanted to know if you could list the link for the PowerPoint again. I was trying to find it.
Oh, yes, I will share the link for the YouTube
Okay,
again, and then I will go ahead and send the slides to everyone that joined today.
okay,
But I will upload that video sometime this afternoon.
thank you.
One question. I wanted to say, what about not just the person, the patient's trauma, but it can be a family trauma. So you have the patient went through something and then a grandchild or a child is going through exact same thing and it's family trauma. And they forget their trauma because they're trying to help the trauma of the family member.
I would characterize that as some of the weathering that
Mhm.
people experience. Specifically, I know I spent some time looking at this not that long ago. The weathering that specifically like Black women experience, how they take the burden of things for their families. And when I say weathering, I mean being worn down in such a way that it impacts you chronically, that it starts to impact your health, your comorbidities, not just, you know, for everyday people, but for lifetime survivors. One of the things that we're seeing is that people who have lived with HIV are developing comorbidities and conditions that they shouldn't have for another 20, 30 years. But from the trauma and the sustained autoimmune illnesses, that weathering, that state of being worn down happens a lot faster. And trauma does that too. Taking on the trauma for others does that too.
Okay.
I think sorry, to answer your question, I think in terms of like how do you manage the trauma that is happening to a family, I think one of the biggest things would just be to validate these experiences, that maybe you're on the sideline of this trauma, but you're still going through it too. And you're still experiencing whatever that impact is, you know, through your grandchildren, through your changing family dynamic. You are just as much valid in experiencing this trauma and feeling your feelings as anyone else. It may be a different perspective, but honoring your own journey, your own trauma, and recognizing it in a way that you can start to heal and
Yeah.
start to heal with a family.
Yeah, well, I come across a lot of some patients that are going through different scenarios, so they put their self on the back burner but not really deal with their own issues. So it's like, you know, their daughter or their son or anything. So I was like, you know, we work with them, but it's like to bring their issues, because I think sometimes they got to deal with them and let the therapist deal with the children before they can help the other child. That's, you know, basically that's what I was thinking, but you always see they put themselves on the back burner.
My favorite thing people always say with regard to trauma is the oxygen mask saying, where you can't help anybody else on the plane if you don't put your oxygen mask on first. If you don't take care of you, if you don't put your own oxygen mask on, you're not going to be available to help anybody else. So recognizing your own experiences and your own trauma, even if it's as a sideline to what's going on, what's happening to you is important too.
Uh,
Okay.
Well, Katelyn, thanks again. We were happy to have you here. And for everyone that joined us, thank you for joining us today, and we'll see you again next month. Enjoy the rest of